IJB. Emma is replacing Derek Jameson, who you'll all know has moved on to a new role. I'd like to formally put on record on behalf of us all our thanks to Derek for the support he's given to us over the last few years. He's been a great asset and it's been greatly appreciated, but we welcome Emma and hope you'll enjoy being around the IJB. Also a welcome to Amy Ross, who is joining the meeting this morning. Amy is a National Finance Management trainee at NHS Grampian and is shadowing the IJB today as part of her induction. So welcome Amy as well. Emma, do we have apologies to note for the meeting this morning? And can you also do the roll call so we all know who's here today?
Thank you, Chair. Could you also please note that the public section of the meeting will be recorded and published online for public access after the meeting? And could all attendees please mute their microphone when they're not speaking? I've started recording and we have apologies from Michael Wilkie from KPMG, and I'll just do a roll call now. Luann Grujon, Chair.
Yes, good morning.
Councillor Dunbar, Vice Chair.
Yes, good morning.
Morning. Councillor Bell.
Good morning.
Councillor Cook.
Hi, good morning.
Councillor MacDonald.
Hello there, everyone.
Kim Crootenden. I see Kim is.
Morning.
Here.
Sorry, I'm having some mouse issues this morning. Yeah, morning, everyone. I'm here.
Thank you. Morning. Alan Gray.
Yes, I'm here. Thanks.
John Tomlinson.
Yes, morning.
Morning. Sandra McLeod.
Good morning.
Alex Stephen.
Morning.
Dr. Caroline Howarth.
Good morning.
Dr. Malcolm Metcalf. No. Chris Littlejohn. Okay. Mike Adams. Jenny Gibb.
Morning, everyone.
Morning, thank you. Jim Curry.
Yes, good morning.
Graham Simpson.
Good morning.
Maggie Hepburn.
Morning, everyone.
Shona McFarlane. Okay, Alison Murray.
Good morning.
Thank you. Alan Chalmers. Okay, thank you, Chair.
Thanks, Emma. And I see Mike Adams has put a message in saying he's been caught up in staffing meetings, so we'll note that. So I want to just start today by saying thank you really to all the social care and health workers who are working in Aberdeen at the moment throughout these really pressured times. We've got a lot of hidden heroes in our system, and whilst it's often the pressures at the front door of a hospital which make the headlines, we're all very aware that there's sustained pressure across the whole system, and that is equally felt by our community pharmacists, our social workers, our third sector teams, our care at home and care home staff, as well as our nurses, GPs and AHP teams. So to everyone working in Aberdeen's large health and care system, what you are doing is appreciated and hugely valued by the IJB, so thank you. And I see people nodding too. As we know, COVID has not gone away and we are likely to have a challenging winter ahead. So I would encourage everyone to stick with the guidelines that we have, wear a mask when you're out and about, get your COVID booster and your flu jabs if you're eligible, and get clued up on where best to go for help. Use the know where to turn to guidance to ensure we all play our part using the right services at the right time to alleviate the pressures in our system. I'd also want to reflect on an expression that I've heard on Facebook, which has resonated with me recently, and that is, the expression is, the whole world is short-staffed, so be kind to the people who have turned up. And whilst these are really uncertain times and challenging times for people, it's really saddening to hear of reports of staff in frontline roles being treated abusively by members of the public. So my message to everyone is please be kind to each other and to remember to respect all staff who are doing the best they can under these really difficult circumstances. So now on to the agenda for today. Do we have any declarations of interest? If anyone has a declaration of interest, please raise your hand. Not seeing anyone, okay. In terms of exempt business, Rosewell travel plan, Emma, could you highlight that for us, please?
Thank you, Chair. Yes, item 17 contains exempt information as described in paragraph 8 of the Access to Information Act. This is applied in this case as disclosure of the amount of any expenditure proposed to be incurred by the authority would be likely to give an advantage to a person or organisation entering or seeking to enter a contract with the Council.
Okay, thank you, Emma. Are people content with that? So we consider that under the exempt business. Okay, thank you. So now on to a video that we're going to show today. So many of you have been involved in the culture work we are doing as an IJB and with our leadership team. As part of that, we are keen to look at ways that at the start of an IJB meeting that we can remember to put on our IJB goggles and to remind us that the purpose of coming together is to transform Aberdeen's system of health and care to be fit for the future, looking at ways that we can support people to stay at home or in a homely setting where it is safe to do so, and to encourage supports which are preventative in nature to help reduce demand on the acute part of our system. So we start the meeting today with a short film on Rosewell House, which illustrates in a very real way the positive impact of a decision taken just at our last IJB meeting. So I'm really hoping technology works for us now. And Emma, will you play the film? Thank you.
So I'm Julie Warrender. I am the transition lead at Rosewell House, this new intermediate integrated care facility, which is the first of its kind in Grampian. My name is Katrina Angus. I am a senior charge nurse based at Rosewell. We aim to provide step up and step down care for the older adult population. So we aim to step up from the community, which enables patients to be admitted for therapy or nursing or medical intervention, as far as possible preventing acute hospital admission. Our step-down care is provided here via our acute frailty unit, so anyone that was admitted to the acute frailty unit can come to us if they're not quite well enough for home, but no longer requiring acute hospital admission. We disable people in a hospital, I think, because we felt if we came to a more homely setting, working with our Bon Accord colleagues to deliver enablement care, the patients would feel a little bit more like they were at home rather than a hospital setting. So it felt right that we opened up this service.
It was very exciting. Obviously it faced its challenges because we were all getting used to a new setting. We're all, been nursing for quite a long time, and I've always been in a hospital setting. But I think this environment is a lot better than a clinical hospital setting for not only staff but patients, because we can work a lot closer, I think, together, and the patients have a nicer environment. It feels more like home. Uniquely, alongside that, we work with our Bon Accord care colleagues who help us provide that hands-on direct care in a person-centred way for our patients. We all work very closely together, so whether you're a staff nurse or you are Bon Accord care support worker or service supervisor or an NHS healthcare support worker, we all do very much the same job. We're very person-centred, so it depends on the person as to their goals. So generally speaking, we'll try and get them as independent as possible, whether that's with aids or without aids, whether they need assistance with the likes of personal hygiene. We every patient is individual.
So nice big single area rooms. Everybody has a single room. It's an ensuite room. So they have their own TV. They can have their phones. There's sockets for them to charge phones, bring in iPads or whatever they want to do. So relatives are free to use our communal spaces, which are our lounges, our kitchens, or our garden space outside on a nice day, and they're free to take their loved ones wherever they wish throughout our building. So the idea is it's a more homely setting in an intermediate facility. So we're not quite hospital, we're not quite home, but we're trying to get that feel.
The occupational therapists have the kitchen, which they take patients to make sure that they can manage activities of daily living, and then they can see if any support is going to be required for discharge. They do a lot of work on the units within the patient's rooms, which is quite a homely environment, just to make sure that they can wash and dress if they need basically assistance with anything when they go home. They do home visit discharges or home visits to make sure that the home environment is as safe as possible for a patient on discharge, and if it maybe requires any adaptations, they will organise that prior to discharge. So the physiotherapists have got a nice gym within Rosewell. It's quite spacious that they can take patients through to do various work with their mobility. They've got stairs that they do stair practice with to make sure the patient will manage stairs at home. Again, they will be involved in home visits or home visit discharges to make sure the patient is safe mobility-wise at home, and again will provide any aids that the patient may require. They also do a lot of work again within the unit setting around their bedrooms.
We also have a medical team. We work with our Bonacor colleagues who are support workers. We have service supervisors who play a more senior role within our Bonacor care team who work alongside our registered nurses. And we have assistant managers for Bonacor care that help us support the Bonacor care team as well as our managers from an NHS perspective. On average, on a daily basis, I think we have about 30-40 members of staff between our therapists, doctors and nursing team.
For nursing staff, which includes the NHS staff and Bonacor care staff, we have huddles with the multidisciplinary team, which obviously involves the physios, therapists, OTs and medical staff and nursing staff. We always try and also have the patient as the advocate and they make the decisions for themselves. However, obviously if they do not have capacity, then we still try and do what they want us, want to do, like their discharge destination safely, but we also work very closely with their families. We have a lot of communication with the patients and their next of kins.
So setting up the service has not been without its challenges. I think bringing two teams together undoubtedly has been challenging. However, it's had really positive outcomes for our patients in the fact we're learning from each other. Our Bonacor colleagues work in a real enablement way, which we have learned from that.
Healthcare support workers have been very keen in doing training in observations, so like your blood pressures, blood glucose monitoring, venipuncture, cannulation.
So we're really looking for anybody who wants to work in something completely different and unique. Somebody who's willing to drive a service forward and do what's right for our older adult population. We're really looking for somebody who's enthusiastic, keen, got lots of fresh ideas of how we could make things better, how we work better with our older adult population to understand what their needs are and how we best meet that. So we are keen for anybody that has a drive, a passion and a care for developing, delivering a service.
I think Rosewell's wonderful. It is putting the patient first. It is very much person-centred. We aren't just looking at their illnesses, we are looking at them as a person. It's a lot more of an intimate environment, so we get to know our patients a lot better. It doesn't feel like you're the nurse and the patient's the patient. It is very much you're having that interaction with them, and it doesn't feel quite so clinical, even though you are there to be their nurse.
Great. Hope you enjoyed that. I thought it was a fab video that really illustrates in real life how Rosewell House is operating and the benefit that people are experiencing, the care they're getting. So now we've got our IGB goggles on, we can move on to our items for today. Our standing items, well, I should say, I will aim to build in a comfort break, sort of around 11:30, 12 o'clock. Emma will maybe just give me a reminder when we're switching agenda items as to the best time to do that. We've got a really full agenda today, so I'll do my really best to keep us on track. So apologies if I'm moving discussions on, but it's just to make sure that we give each of the important topics we have the appropriate time and questioning today. So I'm going to scoot through the first few items, hopefully relatively quickly, to get us on to the more substantive areas. First of all, the minutes of the board meeting of the 24th of August, which is you can find in page 7 of the pack. Are people content, first of all, with accuracy of that meeting? If you raise your hand if there's anything, I see people nodding. Yeah, good, thank you. Are there any matters arising that anyone would like to bring up today from that meeting? No, I'm not seeing anyone raising their hand. Okay, so we'll take them as an accurate record, and we've got no matters arising from the minute. Thank you. The draft minute of the RAP committee, rather than asking John to do an overview, I'm just going to ask if anyone has any questions or comments on the minutes that you'd like to raise today. Please raise your hand if you have. No, I'm not seeing anything. And same with the Clinical and Care Governance Committee. If there's any questions or comments on that, please raise your hand. John Cook.
Thanks, Lauren. Yeah, just a brief question. It's towards the top of page 27 of the pack, and there's a comment about psychological trauma training being given to mental health and learning disability frontline staff. And I wondered if the email on that could go to all of us rather than just those on that committee, because it feels like quite an important thing. What was that?
I think that would be appropriate, Chair and Councillor Cook. Yeah.
Okay, thank you. We'll take an action then to make sure that email's circulated. Great. Any other questions or comments on that minute? No. Okay. Thanks, everyone. So we'll move on to item 8, the business planner. Again, just open that up for questions or comments from people today. Alec, is there anything you want to say by way of headlines for that one?
No, not really. Just to say that, I mean, I think it speaks for itself, and the papers are on the agenda. We'll try and push it out a little bit further because we've only got two meetings on there, so we'll try and push it out a little bit further for the next meeting as well. So you've got a little bit more in terms of what's coming over the next 6 months or so. Just one other question. I did try to come in during the roll call, but if we could just note that there was apologies provided from Angela Scott. I said I'd pass those on.
Thanks, Alex. We'll note that. Okay, I'm not seeing any comments on that on the business planner. So moving on to item 9, the Chief Officer's report. Sandra, over to you.
Thank you very much, Chair. Just very conscious of your introduction and also conscious about the need to be moving swiftly through the papers today, as you said, a heavy agenda. So just really to introduce the Chief Officer's paper, there's 2 recommendations. One is to note the paper and the other highlights our scheme of governance, which is looking for agreement to bring that back in 2023, and the context of that is held within the paper. The paper, as usual, gives an update on our local, regional and national key issues that we wanted to highlight for the IGB, and also how we're working at an operational, a tactical and a strategic level to continue to deliver on services across there. It has examples of how we're engaged and engaging with people with both lived experience, for example, through the Marywell report, and how we're learning to work with our local communities, for example, through the Health Improvement Fund, and continuing to learn how we can progress that. It also highlights how we're continuing to work with our other partners, particularly our public sector partners. And an excellent highlight is the locality working, where we can see that the impact of health visiting now based within localities has been strongly linked in with education in early years and has really helped what was issues such as toilet training be done in a much more cohesive and collective environment rather than individuals. So we're really starting to see some real strong evidence of impacts for people in there. It also highlights the focus the IGB has had on culture and how we continue to work together across our system and the strength that brings. It also focuses on our staff wellbeing and on the recruitment campaign that NHS Grampian is supporting right across us to help us look at how we can encourage people to come and join health and social care for what is a continued and sustained career. The only other thing I would say is we have had a focus on immunisations in the paper as recruitment, as I say, and staff wellbeing and how we're planning to meet the pressures of winter. You will be aware, and IGB members will be aware, that we are under and continue to be under sustained and enduring pressure across our health and social care system. I do fully appreciate, and I'm sure members have had highlighted to them how different parts of the system are under pressure, but this is a complex system that we work in, and each of those areas are interdependent and interrelated. We look after people and support people and encourage partners to work from a home-to-home philosophy. And I think at any point, for example, when we've all worked together to promote to save lives, as Luann said right at the start, having our immunisations, wearing our masks, staying at home, making sure that we're doing our lateral flow testing, all of that impacts, but as we've had to cancel operations and things like that, as that happened right at the start of the pandemic, everybody now is working really hard to start to overcome that legacy. But that has impacts on our primary care colleagues and GPs, it has impacts on our social care colleagues, and then right across, everybody's working hard right across the system. So just really mindful of that. I'm happy to take any questions.
Thank you, Sandra, for that overview. I see a few hands up. So I'm not sure which order, but I'll go for Maggie and then Philip.
Hi, everyone. Hi, thanks, Sandra. That's a really comprehensive report, and it's really a pleasure to read some parts of that. The particular question I had was around recruitment, and it was taking on board what you just said about the different pressures on the system as a whole. There's been some concerns, obviously, from third sector around recruitment themselves, and I'm sure everybody's aware that there's a lot of effort going into recruitment across the board, you know, with organisations offering sort of money in order for people to come and join them. I'm just conscious that as a system, we seem to be drawing from the same group of people, and the same group of people are moving around. And within that context, obviously, people will vote with their feet and go to places where there's better terms and conditions, better salary, and potentially more security. And it's whether that weakens other parts of the system if we are drawing from the same group of people. And sorry for the long-winded sort of intro, but the question is really about the recruitment process. Are we looking at trying to encourage new people into the system? And if so, how are we doing that? And because my concern is if we are just advertising, what we risk is we move people from areas where we're going to need them later and thereby create pressures by solving other problems elsewhere. So I just wondered what your thoughts were on that.
Okay, I'm more than happy to respond to that, Maggie. I think it's a really valid point that you make. In the recruitment campaign, the ask that we had and the work that's been done across with NHS Grampian is they're firmly aligned in with each of the partner agencies, so each of the 3 health and social care partnerships, each of the councils, but also we're very mindful, particularly in Aberdeen City, that all of our social care, for example, in the main is delivered by our external providers. So to have a recruitment campaign that's only looking at public sector will just undoubtedly do just exactly as you've described. The recruitment campaign is less about saying, just the normal recruitment, and it's more about saying this is how fabulous the North East is, please come and work here. And it's also about, there's a lot of videos that are getting done about people who are saying this is what my role is, this is what I do, this is what you can come to do. We're also aware that within, we're not talking new issues here, just exactly as you've described. These are decade-old issues within health and social care in Aberdeen and within Grampian across there. These are not issues that are just new today, they're just becoming more exacerbated. But I do think we're in an opportunity now where there are some areas whereby, unfortunately, some sectors have had redundancies. Some people are looking at new career changes. The pandemic has shifted people's views on what's important. and how they can make a difference to, you know, to communities and society. And I think that's what that is what we're trying to focus on with the recruitment campaign. So it is about saying, we live in a fabulous area up here in the northeast. And I mean, Grampian, you have the sea, you have the Cairn, you know, you've got everything within your doorstep, sales, everything there, you know, and it's a really vibrant economy here. So I think it's about promoting that, and it's not just locally, it's wider. It's about looking across Scotland, it's about looking down England, it's about looking everywhere and saying, you know, this is a fabulous part of the world to come and work with us, come and do here. And what we're achieving is health and social care partnerships, again, really trying to promote that message. So very cognizant of what you said, Maggie. And I think once we get the videos out, we'll be looking for people to share them in their absolute widest connections that we can. So, you know, somebody away down in Cornwall, I know they've got lovely sea, but we've got better up here, don't we? So
Thank you.
Thanks, Maggie. Really good question, though, as well. Philip.
Thanks, Chair. You know, another good report, Sandra. I don't know whether you've got better sea. You've certainly got colder sea than Cornwall. That's for sure. But I'm thinking now about the winter planning arrangements. So we've heard some very interesting comments from some quarters that, you know, only dial 999 if you're actually dying. Don't go to A&E unless your leg's fallen off. I mean, I'm just embellishing a wee bit, clearly. But so the winter planning arrangements, so the A&E are already experiencing high demand. This report says. Can you give us a flavour of what sort of demand they are experiencing? I mean, is it people rocking up with legs falling off? Is it you know, silly cuts? I mean, what's happening just now?
I would say the one thing about what's happening just now is that there hasn't really been a foot off the gas, Philip, for want of a better expression. When we talk about it's sustained and enduring pressure that are across all of the system, what we're finding is that in some cases, as we'll all be aware, our GP practices are under considerable pressure and have been for quite some time. They've had to deliver systems in a totally different way, but as people are becoming more ill, with their mental health, with chronic illnesses and disease, the first port call that people will go to is their primary care services, their GPs. There's a significant number of increases there. So they're seeing way more demand than what they've ever seen in their system. People being people, sometimes if they stay near an A&E department or stay there, if they can't get through to the GP or can't get through to 111 instead of that, they might just turn up at an A&E department. So what that means is that we've got significant numbers who are turning up that may well be minor injuries, minor there, or can be easily redirected. So for example, could have been seen at pharmacy, could have been seen by, we appreciate with the GPs, but could have been self-directed to, you know, some of the other services. All of that takes time within an ED department. So for every time that we're spent assisting and redirecting to GMEDs, redirecting there, all of that time, then what that means is that we've got ambulances potentially stacking at the front door. We've got people in community who are having heart attacks, who are having strokes, who cannot have, you know, they're having to wait for their calls as we're trying to put ambulances through ED. So this is not about people just rocking up with, you know, everything there. It's about, I think that's probably the part it's trying to explain, is that there isn't one part of our system that doesn't impact or be connected to the other. It's that whole bit, and everything that we can do, every grain of sand helps. So everything that people do that can be looking towards, do I really need to go to A&E, or is there another, if I know who to turn to, can I do that first? I think that's what we're asking, but not people should be seeing the right health professionals when they need them.
All right, so if I can ask a supplemental, please, Chair. So what sort of triage is being done at A&E? So you turn up and you know your fingers hanging off, or you know, if you're suitably triaged, you go to the right department. But clearly, you might turn up and you could be told, no, go and see your GP. Or you know, we've got some you know, some specialist nurses here who could actually look at you. So is that happening? Is there much triage going?
There's significant triage that goes on, Philip. So as part of there's a huge amount of work that's been done right across our whole system to look at that. So for example, within triage and ED, we've recently opened another triage area. So we'll have 2 triages. We've employed extra staff. who will specifically look at triage. On top of that, there's triage areas which cut directly from ambulances, so they come in one way, but also reception triage is another. So people report to reception, then they're seen by triage nurses. We've also recently recruited quite a number of additional staff within ED to look at being able to open additional beds. So for example, there's 8 surge beds have opened, so capacity has been increased. So capacity has been increased through staffing, through how we work through, and also by working closely with both our SAS, Scottish Ambulance Service colleagues, and also working with our GMED colleagues. So triage is absolutely active, and there's the flow navigation centre as well, whereby people can call in. There's 111 where people are triaged, GMED's triages, the COVID line triages. So depending on what line people call, each one of those will have a triage facility.
Thank you. I'm curious to hear that ambulances are triaged as well. I mean, you know, because clearly when you
Sorry.
get, I said, yeah, go on.
I was going to say, so there's an area where ambulances come in, but there will be a requirement for ambulances to be triaged, because sometimes 999 calls or ambulance calls, there will be different types of people who are waiting to come in. So somebody who has who requires to go directly into resuscitation, or somebody who's maybe possibly had a fall and has no fractures or visible injuries, may well be triaged ahead, as is rightly so. But that's a clinical decisions, and that's clinicians who are making those important clinical decisions.
Right, I understand. Thank you.
Thanks. And I think there's an action maybe from there for us to think about, is maybe doing a briefing on the winter planning arrangements for the IJB that NHS Grampian are planning at the moment, and we'll look to see whether that goes around by email or whether it comes to the next IJB meeting. But maybe just to give that some assurance to Philip on his questions, I think that would be useful to do. I'll move on now to John Cook, and then Leslie.
I had another question on the recruitment side, which has partly been answered. It was just that we've got 300 folk being recruited across Grampian as a whole. I just wondered how many of those are NHS, how many of those are social care, what's the kind of split between the city, the Shire and Murray? So
apologies, but I don't have those figures off the top of my head. I do know that we've got, so within, from an Aberdeen City perspective, from a Aberdeen City Health and Social Care perspective, we have providers from both our independent sector who are around that recruitment, so they'll be on the back of that as well as our NHS staff. So we've got a pretty even basis on what we're looking for. But I can certainly come back with the right figures if that's of interest.
It was more curiosity, and apologies, Sandra. That's the kind of question I really should have given you advance notice of. But no, I take your point. I take the point also you're making about the fact we need to encourage people to live in the northeast, because we've got a lot of things going for us, and that's because I think if you look at GP numbers across Scotland as a whole, it's gone up 5% in the last decade, but it's gone down 5% in the northeast. So it is a case of attracting people to be here.
Yeah, thanks, John. And I note John Tomlinson's comments in the chat about in future, can we hear about the results of the promotional work in terms of new people coming to the area. So that might be something that we could pick up in the workforce plan that we get annually, to see how many additional people are coming, because we absolutely don't want to be just moving the deck chairs. I think, you know, as Maggie's earlier point, it is about bringing new people in to the system. So maybe that would be a helpful overview that we could have in our workforce planning report, which we get annually. Yeah, okay. Thank you. Thanks for that question, John. Leslie.
Thank you. Sandra, thanks for the report. It's very comprehensive, and despite the current challenges that we're facing, there's some good news I think within it as well, which is great. My question is really just about the Marywell redesign. At 3.4, you talk about there being service user engagement in terms of the design, but it hadn't actually commenced, I think. Are you able to give any further update on, using lived experience in terms of, maybe better design of, like services?
So in regards to this one, the Marywell practice, that was, we're mindful, if you recall, that that was the service that was predominantly round about homeless people who then went into their mobile. We're looking at is to understand and help design the service that would meet those complex needs. So that's work that's still ongoing. They're still going through those workshops at the moment. Sorry, Leslie, I'm not sure if that's your question or whether it's are we engaging wider with that? But that methodology is something that will be firmly embedded as we move forward. Yeah.
Okay, thank you.
Thank you, Leslie. And Sandra MacDonald.
Thank you, Chair. Coming back to what you were saying in your report, Sandra, about recruitment to the North East, and I would echo others' comments about what a wonderful place it is to live. Can I just, I suppose one comment is that because of the downturn in the energy industry, that was often something that would attract families, and then one maybe worked in the energy industry and you know the other would work in health and social care or NHS or wherever it is. But my question really is around, are we also going to help target those that haven't necessarily always worked in this sector, like men, for example, and you know what can we do? I was very conscious of the you know, the excellent Rosewell video and what a wonderful place it is too. But it was women, and I thought, you know, we really need to push that envelope out a bit, and I'm hopeful that that is part of your thinking when doing recruitment videos and all the rest.
I'll certainly take that back, Councillor MacDonald, because I think that's a really valid point. That when we're looking for that, we do have a lot of individuals who've worked through the health and social care sector, so it'll be, I think that's a really valid point. Thank you. Take that.
Thanks, Sandra. Leslie, your hand's still up. Was that from previous? Okay, thanks. John Tomlinson, final question from John, and then we'll move on.
Yeah, thank you. It was just on the National Care Service, paragraphs 326 and 327. Do we know what happens from this point onwards? I think I've heard that they're looking to maybe get legislation in place by next summer. So presumably there's some kind of process that we would be involved in. Have we heard anything yet?
I'm going to bring Alison MacLeod in just to confirm, but my understanding is that we will just wait to hear. Government will review all of the consultations that came back in, and we'll wait to hear what's coming forward. I'll bring Alison in if she's got anything else to add.
Yeah, thanks, Sandra. No, nothing particular more to add. Just to confirm, the consultation was submitted last night, and the official response said basically more or less what Sandra just said there, that you know they're going to take the next few weeks to digest all of the responses that they get, and that they do intend to have more consultation, and they will be coming back out to people, but it will probably be sort of towards the end of this year into the beginning of next. The only other comment I could make was at some of the sessions that we had with the Scottish Government, they did say that they were planning or they were hopeful that they would have a national care service in place by the end of this parliamentary session, which is, you know, sort of 4 and a bit years away. So, you know, that I think it's going to, these things do take time, but the policy department, we're certainly seeing looking to get some sort of bill in place by the summer, as you say.
Thank you.
Thanks, John. Thanks, Alison. So I suppose a few things there, just from maybe taking an action to look at getting a briefing on the winter planning arrangements around IJB members, and we'll have a think offline about how best to do that, and also just some areas that we'd be interested in hearing about in our future workforce planning around new people coming, but also what we're doing around targeting, I suppose you would call non-traditional groups into this workforce area. So hopefully that's been useful, and thank you everyone for your questions. So are we content to approve the recommendations, which is to note the details in the report and also agree that the scheme of governance review will commence in 2022, with the final scheme being reported to the IJB in the spring of 2023? Yeah, okay, Thank you everyone. Great. Thank you. So now on to the next item, which is the meeting dates for next year. Is it Steph that we've got to talk to that? Do you want to just briefly introduce that, Steph, or is it open for questions?
I can just quickly introduce, if that's okay, Chair. Thank you. So just as stated, these are the proposed dates for next year. I would just highlight that the first set of dates to March has already been approved by the IJB. It's just listed in there for completeness for the report. And just as a bit of explanation, due to the council diary for next year already being approved, and as a result of the local government elections in May, the committee diary has kind of shifted a little bit. So the dates are slightly shifted from what we might have had previously, to allow for the timing of the statutory council meeting to get appointment of members and such like. So if just basically be grateful if members could highlight any issues with the proposed dates that we're not aware of. Otherwise, they're just presented for approval today. Thank you.
Thanks, Steph. Any questions, comments for folk? I'm not seeing any hands up there. So are we content to approve these and agree that the meeting schedule will be published on the websites as appropriate? Oh, John Tomlinson.
Yeah, so it's just a quick point. There have been clashes between the RAP committee and the NHS audit committee, which had been resolved and seem to be cropped in again. If that could be checked out for me, please.
Absolutely, no problem. We'll do that. Thank you.
Thanks, John. Yes, we want to avoid that. And I think just for information, we'll put an email around the timing of seminars. Alec, do you want to just say a little bit about that so for folk know? I know it's not in this particular part, but for completeness.
Yeah, thanks, Chair. Yeah, I discussed this with the Chair yesterday, and I know that the seminars have been, we used to do them at the end of the meetings and so on, and things have changed, and have a few sporadic one-offs through the year. But I think what we're going to do is to put out a Survey Monkey just to see what members' preference is for the workshop dates going forward, and we'll get those, and then we could start then programming in the work that needs to be undertaken in the workshop sessions.
Thanks, Alex. So we'll note that in the minute, and you'll know why you're getting a Survey Monkey when that comes your way. Okay, thank you. So next on to the Chief Social Work Officer annual report. And hopefully we've got Graham Simpson with us. Yeah, I see Graham coming up on the screen there. Welcome, Graham. Do you want to say a few words of introduction, and then we'll open up for questions?
Good morning, Chair, and thank you. I'll take your advice and keep it brief to allow time for other meetings as well. So I'm delighted to have this opportunity this morning to share with you and IGB members the annual Chief Social Work Officer report. The report speaks to the work of social work staff across Aberdeen City, and it covers all aspects of social work service delivery, from justice to adults to children's services. There is no doubt that the year to which this report speaks to has been one of the most challenging in the almost 30 years that I've been in social work. But despite these challenges, I'm immensely proud of the efforts and commitment staff have shown throughout the last year to support and intervene to enable adults, young people and children and families to remain safe and connected in their communities as well. I don't propose to say too much more, Chair, but I'm happy to take any questions that members of the board may have.
Thank you, Graham, and I appreciate you keeping your intro brief. So over to any questions or comments from IJB members. Leslie.
When this report came last week to the Public Protection Committee and Aberdeen City Council, I'd commended Graham and the many teams across social work for the excellent work that they've managed to do in what, as Graham describes, is the most challenging of circumstances and at a most critical time. I'd asked last week around, the transition period that young people experience moving into adulthood. So they move from children and family services to adult services, and a question really around the development of what we call like whole family support. And I just think it might be useful again, Graham, to ask that question in this arena, if you like, so that you can detail some of the really great changes that have been developed in recent time and also will be, developed into the future. Thanks.
Thank you, Leslie. And Chair, if that's okay with yourself. Yes, I mean, I think that there is no one single point of transition for young people to transition across to adult services. They do so at many points as well, from whether that is into a justice service or into an adult with learning disability service, or indeed other aspects of service delivery addiction as well, unfortunately. So really looking at this, we want to start thinking much more about the whole family needs of individuals and of families, not just the individual needs, recognising that in supporting younger people, we often have to support better parents to become more effective in their role as parents. How do we support the wider family to wrap around families in an effective and coherent way as well? So really recognising that actually we can't just look at the individual need, we have to look at the whole family need as well. In collaboration with colleagues across children and adults, we are working with ACE, which is a national organisation, to really think about how we support effective transitions for adults for young people with learning disability, building on the good principles of foundations for good practice, and how we ensure these become really embedded into our local practice as well, to ensure that we plan early and effectively for young people. Young people, we know the young people who will transition to adult services many years in advance, so it's important that planning starts many years in advance to ensure the families are prepared and have a realistic expectation of what life and support will be like for them when they reach adulthood. Many families have spoken about the ending of school as being like falling off a cliff, and we want to avoid that expression, and we certainly have worked hard to ensure that's not the case. So very much looking at this from a whole service perspective, whole system perspective, we are looking to ensure that actually that planning begins at 14 and enables many years of planning and refinement to ensure that actually when children and young people do transition across into adults, the families are clear what is expected and who they can turn to for support in a seamless way as much as we possibly can make it.
Thank you, Graham.
Thanks for that question, Leslie, and yeah, really encouraging to hear all that good innovation that's going on. John Cook.
Thanks, Lion. Yeah, there's just a brief question on if I'm reading it right, top of page 56, there's a table that looks at delayed discharge per 1,000 population in the 75 plus area. Am I right reading that right? We've actually made a significant improvement in 2021 over 1920, and in both cases we look to be better than the Scottish average.
Councillor Cook, that would be my understanding as well, and hopefully Sandra will agree with me that I'm reading that correct.
I thought it was the case. I'm glad we're reading it the same way, but just in case, it's probably a well done to those involved.
Absolutely.
Thank you, John. I'm not seeing any other questions, so I wonder if IGB would agree with me to add, and we've got a recommendation to note the report, which of course we are doing, but I'd also like to suggest another recommendation, which is to commend the social work teams in Aberdeen City for their dedication, their excellent hard work over the last year and their innovation over the past 20 months. So if we can add in that as a recommendation as well, and I see folk agree, and we're hugely impressed and grateful for what the teams have been doing and continue to do. They are certainly the hidden heroes that I talked about at the start. They certainly are that, but they are valued and seen by us and appreciated. So thank you. Okay, thanks for that, Graham.
Thank you.
So now over to item 12, financial monitoring of Q2, and Alec.
Yeah, thanks, Chair. I'm not going to go into too much detail either, just to kind of highlight the fact that we have got an underspend on our mainstream services as it sits at the moment, largely due to an underspend on social care in the residential sector. So given the level of occupancy, that's probably to be expected. We do have risks around care at home. We know care at home is increasing, particularly So we're keeping a close eye on that one. We've also seen a spike in our prescribing costs, and I've asked for further information around about what that is and whether it's consistent with the rest of the country. So I'm waiting to get some information back on that, and I'll feed that into the Q3 report. The final point I would make is that there is likely to be additional funding, or there will be additional funding for winter, and I'm seeking authorisation to go and spend some of that money once the detail is announced around about that on the items that are held within the report. There is one typographical error, I think, on the 3.7. We talk about multidisciplinary teams, and the multidisciplinary, I see, is in twice. It may fall within the local government or in the NHS, but it will be only one £740,000. So it just depends on what side that money comes across and what we're likely to spend it on. I think it'll be more likely it'll be spent within the NHS side. Chair, that's all I'm going to say at the moment, and we'll take it from there.
Thank you, Alec. Open that up for questions from IGB. John Tomlinson.
Yeah, thank you, Chair. This relates to the money, but it's also to provision. So maybe see who can come in and answer it. On the occupancy side, Alex, you're saying that's kind of, there's some savings around that at the moment, but presumably we're going to try and maximise the occupancy if that's linked to helping release the pressures in hospital. So is that likely to change through the year? This is at Q2, and are we expecting that to balance out? And secondly, is there more that we could do to speed up that move, and even if it's taking more money, because we could seek to secure additional money if we can demonstrate that we can move it quicker.
I'll come back on that one, Chair. Yeah, I think I mean there's a difficult balance to strike, because obviously one of the priorities of the IGB is to try and keep people out of residential care as long as they possibly can. So we have got that difficult balance, and if we did fill up the residential care in the way that it was done before, then we would have an issue on our hands with regard to care at home, which is increasing. So what we would have is two aspects running at the same time. We would be back up at the level that we were previously at residential care, and then we would be also seeing additionality in relation to care at home. So we would have an issue with that. Both those care at home obviously is mentioned within the paper, and there is confirmation that some of that funding that's coming across will be recurring, and that will help support some of the additional some of the growth in care at home. I think you are right, there could be a movement in residential care as we try to push flow. I think the other matter around about residential care is the under occupancy payments that they currently get if they've not got somebody in their care home at the moment, and some of the financial support they're getting for that is reducing, and that will also encourage that to come about. The other point I would make is the interim beds money that's come forward as well, and I'm seeking to use that money as well to commission beds within the care homes to help support flow. So it will be a kind of fluid situation. At the moment, the accountants can't forecast that with any degree of accuracy until they see what happens at Q3 once we get through the winter. But we do have that underspend of £3 million sitting there at the moment. So I'd still be fairly confident we should be able to keep that within the financial envelope.
I see Sandra's hands up as well. Sandra, did you want to come in on that, or has Alex covered what you were going to say?
I think Alex has covered it quite comprehensively. It was just really to add that although there is the availability, I think we're one of the areas within the partnership whereby we've used our care home beds and work with our providers within care homes in quite a different way. So we have numerous interim beds, and that's been there, as well as we have interim beds within sheltered and very sheltered complexes, which again is quite new. So we maximise every opportunity that we have. Rosewell, bearing in mind, is something else that we do, but also mindful with the unique environment that Aberdeen has. We have about 6 out of our 29 care homes that are across the city. There are about half a dozen whereby we have no access to beds at all, because they're entirely, they don't take local authority funded clients. So again, that's something that we need to be mindful of as well. So it's not the whole 29, but we have some restrictions.
Thanks, Sandra. John, you happy with that answer? Yeah. Okay, thank you. I'll move on to John Cook.
I've got a couple of questions. One actually was going to be in similar vein in terms of the underspend. Normally, if I see an underspend on a budget, I think, yippee, we're saving money. But when there's a big underspend in adult social care, you're thinking, actually, are we then not providing the service that we should? But following on from the answers that Sandra and Alex have just given, would I be right in paraphrasing that as saying, actually, don't worry about it, because we're simply doing things differently and doing things in a way which is cheaper, but also better for the patient? Would that be a fair characterization?
I'm not sure, as your chief finance officer, I would ever say don't worry about it. I think, yeah, we will keep a close eye on exactly what's happening in relation to that. And the other thing I would probably highlight, Councillor Cook, is I'm not, sometimes care at home isn't the cheaper option, particularly when you get to the complex packages, but it's the right thing to do for the individual. So you could be looking at, a £200,000 package in the community to keep somebody in their house. If you had them into a residential setting, it could be half that and even less than that. So there is a bit about, yeah, it's not often sometimes it's not the cheapest, but it's the right thing to do.
Thanks. And then just one more, which, and apologies, Alex, I should have sent you this one in advance, but I only spotted it when I was reading the paper the second time. Paragraph 3.1 refers to a ring-fenced reserve of 2.5 million. But then in paragraph 3.2, there's also a reference to a 2.5 million COVID reserve. Are these two different amounts, or are they one and the same thing?
Yeah, they're two different amounts. We've got £2.5 million for our risk funding. We've got £2.5 million for our COVID reserve as well. So that's in there. It's been acknowledged by the Scottish Government.
Thanks, that's it. That was helpful. I'm glad I read it right.
Thanks, John. Thanks for your questions. Very good. Leslie.
Hi, Alec. I'm just looking for a bit of clarification, I think, here in terms of we've set the budget setting meeting for the 10th of March for the next financial year, but you're saying here in this paper, if I've got you right, that we may not actually know the full financial position for the current financial year until the end of March. Yeah.
Yeah, I mean, we never know the full financial position for that financial year until, or we never know if any, finalised, but we will have a good, as you go through the year, the financial forecast becomes clearer and more accurate, and we'll certainly be using that information for our budget report. So we'll be using the most recent information that we've got. But I do anticipate that there will be cost pressures coming through based on the information that we've seen before us today. So I anticipate that there'll be a cost pressure around prescribing. I anticipate there'll be a cost pressure around care at home. We'll also have the increase in the national insurance rates and the increase in salary costs as well. So there will be pressures around about that we need to kind of build in. But yeah, we don't know right until the end of the it's normally end of April before we know finally what the position is, but I think we should be in a good position by the end of Q3 to have even more accuracy around our financial reporting.
That's great, thank you.
Okay, I don't see anyone else with hands up, so if we're happy, we'll go to the recommendations, which are on page 78. There's 5 of them. I'm not going to read them word for word, but we note the report and the areas of risk and management action on them. We approve the budget environments, Appendix F. We approve the plan to spend the additional funding as outlined in paragraph 3.6 for the winter plan. We instruct the Chief Officer to implement the plan for the spend of additional Scottish Government funds that's outlined in paragraphs 3.7 to 3.9, and we instruct the Chief Officer to provide the IJB at its 15th of December meeting with a report on the exact funding received and how it was allocated. So people content with that? Yeah, thank you. Okay, and thanks Alex for steering us through that. Always very helpful and assuring to get your reports on the position, so thank you. So our next item is general practice update, including primary care improvement plan update. Who have we today that's going to introduce that? Do we have Sarah? Sarah Given with us, who looks like you're in a tropical paradise with your background, Sarah.
Just to convince myself I'm not cold.
Over to you to introduce the paper.
Thank you. So this paper is submitted to the IJB to present an update on general practice in Aberdeen, particularly focusing on the implementation of the primary care improvement plan. It provides sight of a joint letter from the Cabinet Secretary for Health and Social Care and the British Medical Association, which was distributed to all practices in October. The majority of the paper focuses on providing an update on the key areas of the primary care improvement plan, including progress to date and implications of the revised Memorandum of Understanding for each project. I won't go into too much detail now, but I'd just like to open up for any questions or comments the board might have on the content of the paper.
Thank you, Sarah. Give people a minute to get their hands up. So I see we've got John Cook and then John Tomlinson.
Thanks. Just a quick question. Page 97, there's reference to something called a Doppler ABPI clinic. And I wondered if you could tell us what that is. I have no idea, I'm afraid.
I will let Caroline come in this one, who can help me a bit more with the clinical lingo.
So Doppler is basically like an ultrasound, a jelly scan of people's arteries to assess how good the blood supply is, and it helps our nurses in terms of the type of dressing somebody might need. It's a service that was centralised a number of years ago in Aberdeen City and used to run out of the health village. It had been stopped through COVID, but it was a really, really good service with very good results, and the GP sub agreed that we could use that the PSIP to continue to fund that for our practices, because they really do produce good results from it.
Thanks.
Thanks, John, and thanks, Caroline. Good to have you with us for those technical questions. John Tomlinson.
Okay, thank you. Yeah, the report starts off with the perceptions that may be there in the public view. And so this is a broad question. I'm not expecting a definitive answer to it, and it's maybe something that we can pick up in our later seminar as well. But are we doing enough to help the public understand that there's a reshaping of a multidisciplinary team for them, as opposed to the traditional view of, you know, I've got my doctor, I've got to see the same doctor, I go and see them face to face all the time. Are we doing enough, do you think, around this?
Thanks.
To change that perception?
Yeah.
Shall I come in there?
Do you want to come in? Yeah.
Yeah, absolutely. So I think the short answer is I don't think we are, because people continue to have these misperceptions. So by definition, we probably are not. We've talked about doing this at a local level, and often we've thought, well, this is actually something that's happening nationally across all of Scotland. So we've been promised, you know, some national wording going out. But in fact, ironically, I think tomorrow afternoon there is a Grampian-wide meeting in terms just about that, actually, in terms of a communication strategy for NHSG in terms of what's the changes in general practice. But yes, certainly locally, it becomes slightly difficult, because when you look at, you'll see the level of detail that Sarah's given in her report. And not all practices have access to all bits of the PSIP yet, so it becomes quite difficult to give broad message. You probably do a broad message in terms of this multidisciplinary team, the right place, the right person. But in terms of what each practice has, it's still slightly different. So there's lots of little bits that make it slightly difficult. But yeah, I think we could do more.
Thanks, John, for that question. I think you're probably reflecting a lot of the lived experience we're all hearing, and the more we can do to communicate out why things are changing, how people will experience general practice differently, and the reasons for that would be really helpful. And it's probably needed locally, nationally, repeatedly, lots of different ways. So for people to really understand this isn't about COVID, this is about a sustainable system of primary care. Yeah, Sandra McDonald.
Yeah, I'm pleased to hear that there is some thought going into a comm strategy around this, because I think it is needed, and you know, love it or hate it, social media is just it's there, and you know, we need to engage, I guess. But my question really is on page 97. And I just wondered, under the summary under urgent care, where it said there were 5.5 vacancies, is that a lot, or is that just a few? I just had no sense when I was reading the information what the context of that was.
So it would be about a 50% vacancy rate based on the total amount of ACPs they'd have in place if the team were fully staffed. However, they are assuring us they're still providing a citywide service to all the practices as well. So I think it's a manageable for them at the moment, and they're working to recruit to those posts.
Okay, so I understand. So there are 4.5 in place and they're looking for 5.5. Yeah, understood now. Yeah, silly me. I can count.
Caroline has her hand up too. Caroline, did you want to come in on that?
Well, I was just going to say that I think since that paper, there has been successful recruitment. So I think it's going in the right direction.
Good, thank you. Philip.
Thanks, Chair. So this question is with regard to pharmacotherapy services, and that's on page 96 of the report. So the report says that the pharmacotherapy delivery is based on one whole-time equivalent pharmacy staff member per 10,000 population. So in the city, there's 230,000 population. So does that mean 23 pharmacy staff members? And I think that's also broken down into technicians as well. Is that it? So is that the number that we're looking at for a fully staffed service? Because there's actually less than half that number, I count.
Sarah, is that you can come in on that?
I don't have the figures on just available right now about what's currently in place, but I can gather those and provide them. Yeah,
well, the report actually says though. So it says skill mix of 60% pharmacists and 40% pharmacy technicians. Recruitment's ongoing. So let me see, with the following outstanding. That means obviously to be recruited: 5.5 whole-time equivalent band 5 technicians, 1 whole-time equivalent band 7 pharmacist, 2.4 whole-time equivalent band 8. So that's 5, 6, 8. So that's 10. So that's a lot, isn't it? I mean, how does that actually impact on the services being delivered now, do you think? Or do you know, I should say?
I can give you a little sort of lived experience in terms of. So I think pharmacotherapy is a wonderful addition to our primary care team, and I think we would love to have enough resource to be able to provide what they're saying. The 1 to 5,000 is actually, well, is it 2.5? Was it 2.5? It's a lot more.
There are two ratios. There's 1 to 10,000, but then ideally it's 1 to 5,000.
Yeah, that is ideal. But just
there's not 1 to 20,000 though. Just now, I don't think.
Yeah, no. So I mean, our pharmacy leads remain pretty convinced that they will recruit in time to a fully staffed 1 to 10,000 ratio, which is what we have the resource, and that is in our primary care improvement plan. I don't know about the details in that actual report, to be honest, and that may be what they've got outstanding for that year rather than for the cumulative, you know, as at the stage of recruitment that they should be at. But yes, they are sure in terms of pharmacy that they can recruit, but not in terms of the pharmacy technicians.
Right. So how does that make the service look at the moment? So they're wanting to recruit, but they clearly haven't got it if they're wanting to recruit. So what does the service look like at the moment?
All practices, I think apart from Marywell, have got access to a certain amount of pharmacy time. It is every single practice has got a certain percentage of their allocated quota, shall we say, and there's a rolling, it's like a rollout program for how the rest are going to be distributed. Unfortunately, like every specialty, they have been met with leavers, maternity, illness, and there is a move to create a central hub of pharmacists to allow for that backup, because practices, they get used to having pharmacy time, and when that practice loses their pharmacist for whatever reason, it's a significant gap. So hopefully once we get our central pharmacy hub set up, we'll be a bit more productive in terms of the sort of backfill that we can provide to practices who have a gap in their service at the time.
Okay, thanks.
Alec, did you want to come in?
Yeah, I mean, I guess I was just going to say that, you know, recruitment has been a difficulty for all the professions within the North East. I mean, we're not alone in that. I mean, there'll be similar in the other North East IJBs around about this sort of stuff. I think Councillor MacDonald made the point around about somebody coming in into the oil industry, and then maybe their partner was you know, one of a speciality, you know, medic, and we could but we also lose out, because we need to remember that now the whole of Scotland are recruiting these people. So people who you may have got from the Central Belt coming up north because they couldn't get a job in the Central Belt initially, are now able to get a job in the Central Belt because they've got the same sort of funds we have. So we're all fishing from the same pool around about that. I mean, Caroline's given a good example of how they're managing the pharmacy as best they can. If we could recruit more pharmacists, then we would recruit more pharmacists and pharmacist technicians, and then that would help to support the primary care sector as they're going through their difficult period at the moment. But because we can't recruit those people, then we're just having to make do with what we can at the moment and use that resources efficiently as we can at the moment. So I think what would have happened if we had been able to recruit, we would be in a better position to deal with some of the additional demand that's coming up on the primary care sector at the moment.
Yeah, so a supplemental, please, if I may. So somebody has decided upon this ratio of one whole-time equivalent pharmacy staff member per 10,000 population. But if that isn't possible, then perhaps that ratio should be looked at again. You say you're managing, but it doesn't seem a realistic ratio, though, does it?
Well, I mean, the ratio there'll be a basis behind the ratio. I'm quite sure of that, and that's what we're aiming for. And you know, if we could staff to that level, that we would. If we have to consider skill mix and so on, then we could do that. But we also have to remember that the GP subcommittee have an important role with the allocation of these funds as well. So even as an IJB, if we decided to reduce that ratio, the GP sub might not agree with that, because there's obviously a basis behind the ratio that had been agreed in the first place. So I think, yeah, I get what you're saying, and in some cases what we would do is we would consider skill mix, we consider whether other professions could help support that, and so on. But I think we also have to be mindful that in terms of how we influence this, we've got the plan's been agreed, it's been agreed by the IJB and the GP sub, and we need to recognise their role in the PSIP funding.
Okay, thanks.
I think what we've heard at different points today is that as we've recognised, is there a strategic risk around workforce, whether it's pharmacy staff or others. And I would be interested to see in our workforce plan just how realistic the targets are. And maybe there's a wider conversation as well about the numbers of people that are being trained into these professions, and seeing if there's if the right number of people are coming through, because we know about retirals, but we need to, I suppose my assurance would be, are there lots of young people going into the pharmacy profession and going to come out in a few years and help the system? So I think we can take that wider as well and maybe look at that as a Grampian question, just about what the longer term planning is around these different areas in the workforce. So that maybe take a note of that for the minute, because this is an ongoing issue and risk for us. So yeah, thank you, Philip, for raising that. I think it's really important. I'm not seeing anyone else with their hands up just now on this one. So if I go to the recommendations, we're being asked to note the report, the content of the report, and we will have updates in the future. So are people happy with that? That we move on to next item, but we make a note of the how again this highlights the workforce risk and see if we can look wider at how that's been addressed in the longer term. Yeah, okay, thank you everyone. So our next item is item 14. Oh, Emma.
Sorry, Chair, I'm sure you're aware, but just to let you know that we have people joining for item 14, and they said they would be available at 11:40.
Okay.
I don't know if you want to move on or how you want to deal with it.
Okay, so they're not joined yet. So why don't we go to item 15, if we can do that, and then come back to 14 later on in the morning. So item 15 is the Grampian-wide Mental Health and LD programme. Who do we have introducing that for us this morning? Do we know? I don't know if it would be Kay Dunn or Sandra or Alex can maybe help us out.
Hi, Chair. I think it's
It's
Kevin or Jane.
It's Kevin and Jane. Kevin Dawson and Jane Fletcher.
Okay.
Are they on the call?
I'm not sure if they're on the call. If not, we could take a little comfort break and do that now.
That would be helpful.
That'd be a good idea. Okay, so let's come back, say 11:25, 8 minutes to quickly stretch legs and come back then, and then we'll get on to those items. Yes, smiles. Okay, good. So yeah, we'll see you back in about 8 minutes. Okay, I make that just 11:25 now. Just wanting to check that we've got folk back. Emma, can you please just check we're quoted before we get started for this next part?
Yes, we are, Chair.
Okay, thank you. So I'm wondering then what order we're going to take things in. I see Jane's with us. So are we going to go to item 15 first? Because I think it was Alistair Palin and Maggie White were going to join us at 11:40. Is that right? Yeah, it looks like it.
Yes, that's correct, Chair.
Thank you, Emma. So Jane, is it yourself and Kevin that are going to introduce the item 15 for us today?
Yes, it is. I'm going to pass to Kevin. He's just going to do a brief introduction to this, and then we're both happy to answer any questions on the paper.
Yeah, I might have to switch off my camera. I've been having problems, but Key left for a secondment with the Scottish Government on Friday, so you get myself and Jane today. So this is on the back of previous reports that have come to the board, and it's an update on the cross-system Grampian transformation programme for mental health and LD services. Obviously, there's a lot happened since in the last 12 to 18 months. So it's kind of broken down into sections. There are 6 recommendations, 2 for noting, 2 for approvals, and 2 for instructions to officers. So the first section is really about the background to the transformation programme. It's quite a lengthy report, so I'm not going to try and summarise everything. The bit I'd probably want to highlight there is we have prioritised doing something about the public engagement group, so we can get that lived experience input to everything we're doing around about the transformation programme. Then the next bit is, if you like, what's happened in response to the COVID pandemic emergency, and it goes through the 3 operational phases: Rainbow, Home First, and Snowdrop. There's a wee summary at Appendix 2 that kind of summarises that quite helpfully. Probably just highlight that we did maintain essential and critical services. We used the RAG status for all patients and clients to focus efforts. Highlight the bed changes and consolidations at RCH, and the increased use of Near Me and other digital technology, but at the same time maintaining critical and essential face-to-face contacts. Then probably the bit that's most important is the final section, which is around remobilisation, recovery and renewal, which effectively is the resetting of the cross-system transformation programme. And things that are well known to the board is there has been a wee bit of pressure around about inpatient beds. There is increased demand everywhere. It's not just in secondary or specialist services, it's in absolutely every provider of mental health and wellbeing support. Third sector colleagues have been saying that as well. So ballpark, it looks like a 25% increase in demand. And that we're trying to increase our outpatient face-to-face contacts because we know there's a need for that. We have increased it recently, but we're trying to increase it more. The other bit I'd probably highlight is we're part of the Health Improvement Scotland Reducing Resilience in Inpatient Beds programme. We were asked if we were interested in, to be fair, HIS were really keen to have us on board, and they're quite impressed with some of the work we're doing locally. And then the final bits are really just setting out the governance strategy and the pathway approach. We seem to have second-guessed the government strategies quite well on that front, and it seems to be dovetailing almost exactly with the way funding streams are getting announced for the renewal funding. And probably the main thing for the board in that section is to look at the year 1 priorities. That's as they are just now. When announcements are coming in, we are having to sort of relook at that fairly often because they're coming with prescribed requirements to do things in timescales. So that may change a wee bit, but that's the planned major items for the next. And I think there's a wee appendix at 5 that kind of summarises the pathways, and the priorities are set out from on page 11 from 3.37 to 340. And I think that's probably it. Is that okay?
Thanks, Kevin. That's great. That's a helpful overview. Open that up for questions from colleagues. I see Philip.
Thanks, Chair. I'm probably being really dense here, but how can you align near me with a red, amber and green status? I'm obviously missing something here. So, and in particular, where would the amber fit in?
Maybe I should, the red, amber, green was a way of prioritising clients and patients, risk factors, level of needs. I'd have to say in mental health settings and LD ones, slightly less so in LD, that can fluctuate really quickly. So it can fluctuate from the beginning of the week to the end of the week. But it was a way of targeting the resource because we were instructed to maintain services for everyone with mental health conditions. So it was just to make sure so if you like, if somebody fell into that red category, they almost certainly would have been seen as essential and critical for face-to-face contact. So we would that would have been one of the options for that. Those people would be that somebody going out in the full PPE to see them, or the person coming in for us to see them in a more controlled environment. In Aberdeen City's case, that would have been at Royal Cornhill, around about the unscheduled care hub that was set up. Does that clarify it a wee bit? So near me, if you like, was more for routine reviews. And it's, you know, if you speak to any of our clinicians, it's got limitations. But some patients and clients actually prefer it because it's a bit more flexible. They can fit in round about when it suits them. But really, that was more for more routine reviews. For some folk, it were red. That might be enough, you know, because that personal contact with a clinician or their practitioner might be enough to keep them safe. On the other hand, it would be picked up there, and they would maybe see them the next day or whatever. Does that help explain it a wee bit?
Yeah, well, the red and green makes perfect sense. So where does amber fit in?
Right. Well, amber's the same, I guess. I guess maybe these. I'm going to oversimplify it. So my clinical colleagues would absolutely crucify me for this, but basically, and this is very rudimentary, so forgive me. The greens are maybe cases that need less frequent review. So that might be a review every couple of weeks or once, you know, or they just need a welfare check to make sure they're okay and they're okay for the next scheduled review. The ambers are probably people that we would be more concerned about. So they would maybe be getting reviewed every week. So it's about frequency of contact, if you see what I mean, but it changes. And I would have to be, as I've said at previous boards and governance groups, that has shifted. You know, if we looked at our green, amber and reds 18 months ago, it's shifted. So we've got a higher proportion of reds, ambers and less greens now. And that's just because the people have got increased need with the way things have been with them being isolated and one thing and other. Does that help?
Yeah, that's certainly making things clearer. So do you actually allocate an amber to someone who wants to go, who you use near me on? I mean, or do you just kind of say, well, I'll keep an eye on them, but it's not actually amber. It's just that's what this model kind of fits in with.
No, all the patients and clients are either green, amber or red, but it can change really quickly. So they'll all get their reviews. So if an amber's scheduled to be getting reviewed every week, and it might be by a number of people in the team, it can be escalated or de-escalated at any time.
All right.
You know, so I'm being honest. It's highly unlikely that a red will go to green because there'll be reasons that are red. So even if they're fine, they might still they'll review you again on Friday after seeing them on Wednesday, if that makes sense. Yeah. So it's a fluid kind of system, and that's why, if I'm honest, some clinicians don't like it because it is a judgment call, but it's what they do every day anyway, and it's what they've done for years when they've been seeing patients and getting contact with them.
Okay, thanks. So, and if I may ask then, so amber, amber could go down to green, could go up to red. So who actually tracks that? I mean, clearly the clinician hasn't got time to do that.
No, the clinicians do track it. Because you know the assessment. The assessment's based on their last contact with them, if you like, or it could just be a telephone call comes in. and we'll know and that could be agreed, and we could say, oh, this is very unusual. We need to escalate to that to Reg. Somebody needs to go and do a home visit, or we need to get them in for an appointment tomorrow or whatever. Does it?
Yeah.
So it's
okay. Thanks. Thank you.
Yeah, thanks for that question, Philip. Alison Murray.
Hi, yes, just sort of one thing Philip brought to mind is that we've had a few, I've heard through the group I help support, that a few people have had children who have been unable to engage via Near Me with CAMHS, this is with CAMHS, and therefore were discharged. And I've had this a few times that children who have not been able to engage via Near Me have found that they haven't been offered a face-to-face alternative. But my other query was actually about sort of overlap actually between CAMHS and community child health. Seems to have community paediatrics, community child health, child development teams. It all seems to have various names, which I presume are all the same thing. But certainly I know that there was looking at doing a new neurodevelopmental pathway within CAMHS, but my opinion wasn't of our experience of going through my son's diagnosis was not considered relevant because he went via community child health. The fact that it took him 5 years of seeing community child health before he got a diagnosis, I just wonder to what extent children who are, or I don't know if this sits within the adult issue as well, but children who are going through that route are being not, that there's been developments and improvements under CAMHS, but other children are sort of been going down a different route for the same issues and are perhaps not getting those benefits of those developments.
Thanks, Alison. I see Jane has her hand up. Jane, did you want to come in on both those points, or?
Yes, CAMHS, sorry, to get my hand in. CAMHS sits under the patch that I look after, so I thought I'd come in at this point. Can I go back to your first point, and that was regarding patients who are unable to use Near Me being discharged. Just to assure the group that the CAMHS department, which is based then in the Links unit and also the unit up in Moray, have capacity to see people face to face, and they do see people face to face. Obviously, if people, again, a similar idea to the RAG status, if people have felt they could be seen using Near Me, many people of that age group prefer that because they are in the kind of digital age and they like that. But for people that are not, there is the capacity to see them face to face. I guess to be able to check on that, I'd need to know who they were because there'll be circumstances, but just to give you that assurance that same as for adult, there's the same capacity to see people face to face for our CAMHS service. With regards to the second part around kind of diagnosis and how we work with community child health, there's a lot of joint working that goes on. That they're working very closely with their partners. CAMHS is a Grampian-wide service, so it's City, Shire and Moray. It all comes under one umbrella, and they're working very closely with their community child health, education, etc. All these different parts. So again, with regards to where referrals come into, there is a CAMHS referral pathway as documents that's shared widely with all GPs and can be shared wider than that with regards to how people come into the services. Again, I think sometimes to be able to check up on stuff, we need kind of specific examples to be able to kind of follow up. Because obviously, if there's examples here where it feels like it's not working, we need to know about that because we need to try and make this as smooth as we can for children and their families. Thanks.
Sorry if I just come in on that. I think it's Yes, I think it's difficult when a child doesn't engage with the service at all. I think that was the problem, and they wouldn't engage online at all. But as I say, I can't talk more about the individual situations. As far as I was more thinking in terms of community child health, children who get a diagnosis through community child health. It's because you can get a diagnosis that route rather than going through CAMHS, and it and perhaps if you're looking at sort of diagnosis routes, you need to ask the question of the people who've got diagnosed through community child health as well, whether, you know, if most people are going through CAMHS and getting referred via CAMHS, that you need to sort of make sure that the people who have gone off on a different route are also being, I think, yeah, just ask the question, the same questions of CAMHS that you're asking of people going via that route to make sure that they're being picked up. If you see what I mean.
I see Graham Simpson has his hand up, so he might have a different perspective as well from social work. Graham.
No, it's just to share with Alison and the board that certainly I know that the Community Child Health and the CAMHS and local partners, education and social work are working together very much on the very issue that you're raising, Alison. We were involved in a call with government officials at the end of last week around how we can actually bring alignment to the pathways and actually ensure there is a much greater, stronger there. So Aberdeen City is one of 5 pilot authority areas which will be working on areas of improvement, and the area that you've flagged is certainly one area that we would want to sort of improve our performance on, and that connections across the system as we go forward.
Thank you.
And I suppose for me, thanks, Graham, that's really helpful, and Jane coming in too. What would be the route then for people that Alison's in touch with, if it's not working for them, just to share that lived experience, not necessarily as a complaint, but as an opportunity to learn and to look at maybe where the system just isn't quite joined up? Is there an easy route in for those type of issues? Sandra?
I'm going to ask Alison MacLeod if she's still on the call. Would that be the care opinion, Alison? Would that be like an informal, route then, just to try to take that forward, or is that more of a? I'm aware that Jane has likely got forums and things that are accessible as well. I'm going to bring Alison in if that is a reasonable solution.
Yeah, certainly care opinion is a really good tool in terms of getting that feedback direct to the service, and the service, providing their response direct back to the individual making the comment. So, we've now formally launched care opinion, so I would certainly encourage folks to use it. That it's a fabulous tool for doing that, for getting that direct two-way conversation that you might otherwise have to negotiate through a million and one people to get the response. So yeah, spot on, Sandra. I'd thoroughly recommend using that.
Thanks, that's helpful, and that's great to hear it's launched as well. So that'll be a really good way of people being able to feedback those really lived experience examples from the system. So thank you, Alison, for raising that. I'm just looking. John Tomlinson's hand is up.
Thank you, Chair. Yeah, reading the report is really helpful. Thank you very much for the detail that's on this. What was going through my mind, and trying to look at it kind of strategically, is with the pandemic and what has been coming through, it's kind of making timelines and everything quite difficult and complex. And so one of the things that was going through my mind was, are we now in a kind of permanent state of transition and transformation? And there are sort of timelines about this being up to 2025, etc. And I was just thinking, in the coming period, for our role as board members, wanting to understand performance, the demands for the service, the capacity that the service has, where we are in terms of transformation and change, additional funding that comes flying in at different times, which changes that again. that in future it would be quite useful to almost try and have a summary alongside this, which would indicate on the demand and the capacity that we have and what that means for people. So it's almost like a performance piece sitting alongside then the changes. Am I making it too complicated in suggesting that might be something for future reporting?
Thanks, John. Kevin, do you want to come in on that?
Yeah, yes. I think we've always been in a period of ongoing transformation. Transformation is a new word, but we've always done service change. Some things have been speeded up and progressed a lot quicker because of emergency response. Others have been delayed. Like we didn't get the public engagement group going until this year, and it would have been done a lot earlier than that. I guess the big benefit is when we were going to be doing the transformation programme anyway, before anybody knew that we were going to have what's happened. But I guess the unexpected opportunity, if you like, is we were going to have to do that without any kind of funding. And now the new funding that's coming in, it is coming in pretty prescribed, but it does seem to dovetail with pathways of care. So that's an opportunity for us to optimise that. I think we would agree, as the folk responsible for delivering the services, we really need some kind of high-level measurement of how things have shifted. If you like, I suppose, I don't know if it's demand and capacity, but it's some kind of measures. Like I said, 25% ballpark. I think we probably need to do a bit of work with all our providers, our third sector partners, and right across the system, so that we can actually get a measure of what the increase, get a baseline, get the measure of what that is, so that we can see that the redesign and the knitting together of pathways that we do will have an impact. So I think it's not an overcomplicated ask, actually. I think it's something that we should be trying to do. And it might have to be quite basic early days, but we can refine it as we progress. Jane might want to add from some of the specialist services.
Thanks, Kevin. I think it's a very reasonable ask, and I think it's actually something that will be helpful for us as well, to actually have a summary like that. It has been a very interesting time working through COVID in our services, as it has across all services. And I think the point that you make about the new government funding, for example, for CAMS, although it's been very prescriptive as to what we can use it for, it's making a tremendous difference to CAMS. There is the issue of recruitment, as there always is, but be able to have more capacity within CAMS to be able to deliver treatment more quickly is really important. So again, when we were talking about CAMS before, it was from a different slant because we were working within the capacity that we had. So it is a bit of a movable feast, but I think with regards to what you're asking, I think that's completely reasonable. And we'll just need to work out how we do that. Maybe a little bit of trial and error to begin with until we get something that's meaningful. Thanks.
Yeah, that would be great, and really welcome seeing what you make of it. What kind of information would work? Yeah, thanks.
Thanks for that comment, John. And it reminds me as well of there was a lot of work done around the transformation of mental health before COVID, and I seem to remember a plan on a page. So I'm wondering if it's just going back and looking at what was there before and what the new, just changing it to reflect the COVID impact and the additional funding that's been brought on, because we're not starting from scratch at all. There's so much been done already. So that's just going through my mind. But yeah, I think we're all agreed something that just is an easy summary of demand, capacity, and what needs to change and how it impacts people would be helpful. So thank you. Sandra MacDonald, thank you for your patience, Sandra.
Thank you, and I think that would be very helpful. I have to say I found the paper quite a challenging read. There were so many aspects to it and really quite a complex area, and there were just bits of it that I'm looking forward to the workshop that's in the recommendations, although I probably would ask that it's not near the end of April personally, but maybe a little bit before that. But that's just because of elections coming up at the beginning of May. But we'll see where it falls. My question was really around the 25% increase that's been mentioned, and you know, I was really struck by what Graham Simpson said about the good work that's been done around children's services. Also, what Kevin Dawson was saying around being ahead of the curve and you know, that things have really started to fit. And I just wondered, 25% is quite a big number, but it's not just the number; it's the complexity, and also you know, whether those are really tricky situations, or you know, some of them will maybe be fairly routine and so on. But I can imagine there's a whole gamut. So it would be good to understand a little bit more about that. And my last point was really around care opinion, which was mentioned earlier. And I'm not asking for any recommendation or anything, but it was just if you could share, Alison, a little bit more information with myself or other members who might not be totally up to speed on that, so that when we're, certainly as an elected member, when we're out doing our community councils and so on, that we have an easy link and to share with people, so that we can pass that information on, would be very, very helpful.
Yep, absolutely, Sandra. We'll send that out in a briefing for all IJB members.
Thank you.
Thanks, Sandra, for raising that. That's really helpful, Alison. On your question then about the 25%, Kevin, Jane, do you want to come back on that? Just a little bit of detail on what it means.
Well, exactly. It's just a percentage, isn't it? But you know, if we give it a wee bit of context, in the city, so you know, our community services, we probably look after about 10,000 to 11,000 people in community settings. So it's a 25% increase in that, if you like. The thing is, that's just our services, and it is right across the shoot. You know, it's across the whole spectrum. You know, every bit of service that's doing something to help people with mental health and well-being, the practice link workers, all the stuff that's been put in place in recent years are saying the same. And there's board members that have probably got much more accurate information in what it is in the third sector. So it's not just, it's a generalisation. So I wouldn't be able, I can't really answer your question. So I can't, it's the whole spectrum. So it's from well-being issues to people unexpectedly getting into terrible sort of depressions or whatever because of losing employment. It's a whole shooting match. And I guess from our point of view, across our system with our partners, we kind of recognise it. And it's the same with our primary care colleagues. They'll be getting the same coming through their doors. So it is everything. And I think the Transformation Board will be actually asking for something very similar to what John's asked, because we've got some, we can get that information, and we've got various work streams, not dissimilar to what Graham outlined around about the adult population, where we'll be trying to define that a bit better, so that we, you know, so instead of me giving you a sort of waffly answer, it's across the whole spectrum. I can say, in this level of service, the increase is this, and it's these kind of conditions. We can give the kind of backs. But difference, I suppose, mental health's always, it's very person specific, so it's different for every individual. So it's always difficult to sort of size that up into this is what it's like out there. You know, if that makes sense.
Thank you, Kevin. I see Alistair Palin's hand was up. Alistair, did you want to come in on that point as well?
Yeah, sorry, I'm really here for the next item, but I can't resist Leanne saying something. Sorry, I'm Alistair. I'm a psychiatrist and medical director for mental health and LD services. And Kevin is quite right. We're always in a state of flux. All my career, we've been in a state of flux and transformation. But I think Councillor MacDonald-John make a really good point, which is how do you measure what you're doing? And I think in mental health, that has been really complex and difficult because it is so individual. And I think with Sandra's support, we are trying to move to get some relevant data sets, etc. We had our performance review last week, or a governance meeting with CAMHS. Interestingly, CAMHS referrals are back probably to the same level, the specialist CAMHS referral rate, to what it was before the pandemic. But what they would say is the complexity of the individuals and the risk around the individuals has gone up exponentially. And we were debating about how can you say that, how can you show that? We look at inpatient admissions. One of my favourite topics, as Kevin knows, we look at inpatient admissions, the number of inpatient acute admissions at Cornhill, the number who are detained, you know, as a marker of severity is double what it was before the pandemic, roughly. So the people who are coming in are much iller. But I think Councillor MacDonald and John make a really good point, which is how do you measure, I hate to use the word performance, because people can come along and say it's really busy, it's awful. But quite rightly, I think people say, well, what does that mean in a system? Sorry, Lou, I hope you didn't mind me saying that.
No, Alistair, your experience is really useful, and I think what I take from what Kevin's saying, what I'm assured about is it's a big number. The demand is big, the extra demand, and it's across the whole system, and that's recognised. And I think that's really important. We're not seeing this as a hospital problem or as a problem in some part. It's the whole system, and that we've got the right people around the table to figure out how we go forward, including people with lived experience through the patient engagement group. So I think it's all about just how this unfolds and develops, but we've absolutely got the right stakeholders around the table, which is assuring to hear. So I don't see any more questions, so I think we'll go to the recommendations and just note the action around care opinion, that information going out to people, and the ask around having a summary about the capacity and demand and what it means for people in the future. I'm not going to read through word by word all the recommendations. They're on page 116. But we have a number of recommendations to note the progress to date throughout the COVID pandemic, to approve the agreed approach for moving forward to deliver the transformation programme, note the process and oversight for the allocation of renewal funding for the psychological therapies and for CAMHS services too, agree the phased approach across transformation programme streams, instruct the officers to schedule an IJB workshop by the end of April, but noting Sandra's point that maybe earlier in April would be helpful from a councillor's perspective. So we'll note that, see if that's possible, and instruct officers to submit this report on progress to both Aberdeenshire and Moray IJBs so that they have the same information as we do too. So people content with that? Yeah, I'm seeing nodding heads. So yeah, thank you for bringing that report to us, Jane and Kevin, today. And I think that's been a really helpful and assuring discussion for us. Okay, thank you. So now we'll move on to our item 14. So we have Alistair, I know who's with us, and I know that Maggie White was joining and was having some connection problems, but I see, Maggie, you've joined us now, so welcome. Hi. I don't know if one of you wants to do an intro to this report, and then we can open that up for questions.
Yeah, I'll maybe do an introduction and then let Maggie speak. Yeah, I was part of a national short life working group organised by the government, and this is specifically around the mental health needs of those hospitalised with COVID and so-called long COVID. And with Sandra's support, we set up a group within Grampian, a cross-system group, to look at taking this forward, as I say, under instruction from the government. And Maggie, who's a consultant neuropsychologist, and Murray Smith, who's a consultant liaison psychiatrist, agreed to kindly co-chair that group. So I'll maybe pass on to Maggie just to say a little bit more and update folk on the work that's been going on.
Thank you, Alistair. I'm having such problems with my Wi-Fi this morning. I'm actually in Ashgrove House, so it's a hospital problem, and so I'm hoping that I'll be able to kind of stick with you today. I do have a couple of slides to show, just to show a bit of the process around this. It's all in the report that we sent in, but I know that sometimes getting your head around these things, amongst everything else that's on the agenda, can be a wee bit complex. So I thought it would
You're breaking up a bit, Maggie. Coming and going. No, you've frozen now, Maggie. I don't know if it helps if you switch your camera off, but then I'm not sure that means you can share your, don't know if that means you can still share your slides. No. Carol, do you see your hand up? A suggestion for what we
I
do?
was just going to suggest if it was possible for Maggie to share the slides, email them to Emma, then perhaps Emma could share them, and then Maggie could perhaps talk to them without video if that might cause a problem. I know some meetings I've been in, folks have had to switch their videos off, and that's helped with the connectivity.
Yeah. I see Maggie's leaving now. If we could get a message to Maggie to forward her slides on to Emma, that would be helpful.
I will just email her just now.
Thank you. This technology is great when it works, but we can't just rely on it completely.
Does it make any difference if we all go off our videos, do you think, or does that not make any difference to people dialing in?
I'm not sure, Sandra. I don't know. Emma, Carol, do you know if?
I don't think so. It's connectivity.
Yeah, I think that's probably true, Philip. Yeah.
So I see Maggie's rejoined us now. Maggie, I'm not sure if you heard all of that.
I am back.
Hi.
Really sorry.
We were wondering if you could share your slides, email your slides to Emma Robertson, and then she could put them up. And then if your camera was switched off, it might allow us to hear you and help with the connection issue.
Okay, let's try that. So, oh, it's not even letting me go on to email. I think it's a real problem today in Ashgrove. So sorry, I'm actually not even managing to, the email is just going round and round. I think it just must be a connection problem in Ashgrove. Are you able to hear me?
Yes, I'm wondering, Maggie, if you switch off your video and then we can at least hear you, and if you can just talk to your slides and then we can open it up for discussion. I think that's probably going to be best.
That's Yes, that's fine. Absolutely. I'll just go sort of read through what I was intending to kind of show, and obviously you'll not have the visuals. Are you able to still hear me just now?
Yeah, we can hear you fine. I will let you know if your connection drops, but we're hearing you clear at the moment.
Okay, fantastic. So as Alistair introduced, this is a service which is specifically for patients who are hospitalised with COVID-19, and it's about mental health follow-up. And in terms of the process of development, there was a paper produced in October 2020 by Nadine Cossett, who's a liaison psychiatrist in Lothian, entitled Managing the Mental Health Needs of People Hospitalised with COVID-19. So this was a Scottish Government paper which laid out a number of recommendations for how we should be assisting people who are experiencing significant mental health problems following hospitalisation with COVID. As a result of that, there was a short life working group, which Alistair mentioned he was part of, and that made a number of recommendations about services that how services should respond in this way. Some of the recommendations were quite general, but they formed a paper which had some more specific service elements. That was the National Short Life Working Group. So as I was tasked along with Murray Smith, partly because as a clinical neuropsychologist, I was seeing a few people coming through my own clinic, obviously with cognitive problems, and also Murray sitting in liaison psychiatry. That was a kind of natural fall for where people would be followed up. So we undertook quite a wide consultation process around that. We had a local short life working group which was set up within mental health services. Are you still able to hear me?
Yes, yeah, we can hear you fine,
Yes,
Maggie.
brilliant. My computer keeps jumping. So Yes, so the local short life working group, which had representation across mental health and across the 3 areas of Murray, Shire and the city, were around that consultation. We also reached out to GPs. We reached out to the psychiatry services, liaison psychiatry services in Murray. So we undertook that consultation process and developed a kind of local model ourselves, which contained a few elements in terms of what we would think was needed for people with post-COVID symptoms, mental health symptoms following hospitalisation. So that involved a line in from primary care, obviously, for where people were had been discharged to a screening clinic. I think one of the things that we're learning across this is that many people have been experiencing quite diverse symptoms, so diverse physical symptoms and diverse psychological symptoms, and a kind of one service fits all is not really something which is was going to meet the needs. So one of the key elements we wanted was a screening clinic where they would be seen by a senior clinician who could help identify what the needs of that person were in a mental health way, but also perhaps follow on to other services. So we wanted to have that central screening. What we do in neuropsychology is see people for a 30-minute screening. So we're not talking about a long appointment with people, but it just to identify those needs. And then that person could be signposted to whether they needed psychiatric input, whether they needed psychological input, whether AHP input was needed, or whether there were services within the wider community that could manage that. But obviously doing that, we need a resource to do that within the clinic. There was specific financial allocation for this. So the Scottish Government were quite prescriptive. They looked at the numbers of people who had been hospitalised across different health boards, and Grampian was allocated 138,000 per year over a period of 2 years, with a possible addition of a 3rd year of funding. So we did have a funding element to work within when we were thinking about what would constitute this clinic. We formed a paper which we then submitted to the Scottish Government as to what we thought the service would look like, but also the recommendations, and that included the fact that we felt that this service obviously should be pan-Grampian and accessible across primary care and secondary care for all the 3 health and social care partnerships. We wanted one single access point for triage, including senior clinician screening. We wanted the service to act as a specialist hub for advice and consultation and training across the health and social care partnerships, because a lot of these people obviously are being held by GPs or may have contact with AHPs or maybe in social care, and to have that kind of outreach to be able to offer advice and consultation we felt was important. To make sure we were using standardised tools to screen patients and provide a baseline, measuring change and evaluating the effectiveness of that, and that this would be a multidisciplinary service, so needed to, because of the complex and varied mental health presentations that there would be. Where we're currently sitting is that that paper was accepted by the Scottish Government, and the funding was released, so we were able to progress with recruitment, and we have another short life working group around operationalising that clinic. So we actually do now, we've progressed quite far with recruitment. We have a liaison psychiatrist in post, Johnny McLaughlin. We have a psychologist in post, Gillian Diker. All the people in post are actually part-time because of the limits on the funding. We have an OT about to start. We have a psychology assistant to help us deal with all the data around this, and we have admin staff. We are thinking around the patient experience engagement. So there's a wider short life working group led by Emma Davis, who is a public health doctor and who is the long COVID lead for NHS Grampian. And we have, so Anna Reist around that group is helping with the patient experience engagement for long COVID. So we're linking in with Anna from our clinic perspective to make sure that we can help capture that. But we've also got, actually through colleagues, a couple of patients or a couple of people who've experienced COVID-19 and hospitalisation with COVID-19, so we've been looking at their experience as well. But I think as the service develops, that patient need and experience is going to be led by who is presenting and how we adjust that. There's also 2 national groups who have an oversight around this. There's a national clinical group, so for the clinicians in the service, they're meeting together and discussing cases, looking at recording presentations, and so that we know that we're offering people a service that is evidence-based. There's a national service development group, because actually Grampian is quite ahead of the curve in this. I think we're the first board who actually developed this service. So in terms of the National Service Development Group, it's getting around the table and seeing where other people are directing the funding that they're getting, and to learn from each other and adapt services where necessary. And we do have hopefully some research around this. We're looking at putting a couple of applications through ethics so that we can actually learn more about this population. I think the last thing to say is, in terms of review, the team are thinking at the moment around the outcomes that we'll be recording, which includes, of course, patient experience, the numbers coming through, the duration, the type of presentations, the outcome of the treatment that's happening through the clinic, which will be individual, but also we have a plan for some group intervention, and putting the needs of the patients obviously central to that. So really sorry that that's just a kind of monologue from myself rather than being able to see the kind of prettier pictures on the presentation, but hopefully that gives you an overview of where we're at with this particular service, and I guess we'll just open that up for questions. Hopefully you've managed to hear all that.
Thank you, Maggie. That was great and very comprehensive, and we heard it all very clearly. I will open up for questions from the IGB members. Okay, I see Philip Bell and then Kim.
Thank you, Chair. Clearly, thanks, Maggie. Clearly, this long COVID is an issue. It's still, has been, it will be an issue, and mental health issues have also been a massive issue during these past 18 months. So, can I ask you? There are three parts to the question. It's all just kind of numbers. I like numbers. Numbers are good. So really, it's how many patients are being treated, how many have passed through successfully, and how do young people differ? So three parts to the question.
Yeah, I wish I had numbers for you with those, Philip. I like numbers as well. How many people have passed through in terms of how many we haven't opened up the clinic yet. So what we're doing at the moment is looking for these people, and we've had to go through a few governance permissions to be able to contact people, because what we want to do, and actually what the Scottish Government was asking us to do, is contact everybody who has been in hospital with COVID-19. But obviously that's a very small proportion of people who've been affected by COVID-19. There's a much wider long COVID impact out there, and as I say, Emma Davis, who's the public health doctor, is identified as somebody who's progressing some of that work. In terms of the numbers that we've had through the hospital, the most recent data pool that we did was actually back in February, and there were 1,040, but there'll be significantly more. I mean, at the moment, there are 60 people in hospital with COVID. So I'm anticipating, and it's a very much a ballpark figure, it's not based because we haven't done the health intelligence count recently. It'll be, other people on this call might know, but it'll be around, I think, 1,500 people who've been through our hospital by the time we get to the end of the year. But that's a very much a ballpark kind of count. The other very important question you're asking about young people, and I have quite close contacts with my paediatric psychologists who've been asking their fellow paediatricians about the people who are coming through, as in the young people who are presenting to them with various any medical outcome or significant impact from having COVID, and we're not seeing that impact is really significant at the moment. But actually, I was at a meeting just before this where I was asking my paediatric colleagues to go back and ask that question again. This is an adult service. I think that we've had some discussion around the cut-off age range, and so I think 16 and over, which is generally where people would be seen in the adult hospital. There wasn't any people under 16 who were hospitalised with COVID-19, so there isn't anybody who we would be needing to direct and see if they were getting the services that they need at the moment. Does that kind of answer?
Yeah, thank you. May I just have a supplemental question, please? So, do you notice there are any differences between girls and boys, male and female, in terms of who might suffer from this depression with long COVID?
I think that's an incredibly interesting question, and I absolutely don't have the answer. And I don't know if there's anything national that in terms of the research that's coming out, because obviously it's quite a hot topic. There's lots of research going on. There's a big study called FOSS, which you're probably aware of, which is the follow-up of people who are hospitalised with COVID in a physical, and obviously they're looking at the kind of mental health way. So I've actually forgotten what exactly your question was, Philip. Sorry.
Do you know? Do you think, or do you know of any differences? The sort of the relative numbers between male, female, girls and boys who are suffering from depression if they have long COVID?
As a result of COVID. So I haven't seen anything which is actually differentiated between male or female. I do think that's a really interesting question, and it's definitely something that we can monitor as we collect data for the people that are coming through the clinic. And I think that that's one of the really important things to get right in this, is to be gathering the outcomes, to be looking at some of the demographic data as well, because it's fine to have national data which looks at this, but
oh, Maggie, we've lost you.
Very. Oh, am I back?
Yes, yeah, we can hear you again.
Yeah. So yes, I was just saying that it's important that we look at this data so that we know how Grampian specifically has been impacted, so our particular demographic, but I don't have an answer, Philip, to that in terms of, I'm not aware of the wider research, but as an impression, we're seeing both males and females coming through. So
okay, thanks. And perhaps in Grampian Rowies are the magic ingredient that will actually differentiate. Thank you.
Oh, control group with Rowies.
Okay, conscious of our time and one other item to get through on the agenda. So a few hands up. So I'll go to Kim and then John Tomlinson. Kim.
Thank you, Chair. You'll be glad to know Philip asked part of my question. So I just wanted to ask, just bearing in mind the report that we've just had around the pressures of mental health, it was just around the capacity. I know that you talked about recruitment into this and things, but about capacity of the overall system and whether you're kind of robbing Peter to pay Paul to provide this service. And the other thing, I appreciate the funding and the money, it's all been talked about, is around those who've been hospitalised, but is there any movement on the horizon around those with long COVID that never actually came into hospital? Because there's quite a number of those that are struggling. Thank you.
Yeah, completely and really valid questions to ask. And I think, yeah, there's no way around that. I'm absolutely delighted that we managed to recruit to the long COVID clinic. I want to emphasise they are all part-time staff, so it's like 0.4 of a psychiatrist, 0.6 of a psychologist. But yes, well, one of those people was coming out of training, another person was transferring from another service. So you're absolutely right. All the mental health services are creaking under the already sort of significant demand that they had to deal with, and then COVID has accentuated that in a number of ways. So I don't really know how to respond to that question other than to say, yes, there aren't enough of us in terms of psychologists on the ground, and I'm sure that's the same in psychiatry and across the system. Nurses, we know, we're just absolutely desperate. So all I can say is it's quite small numbers in terms of part-time work, and I think it's a good focus, and hopefully the learning from the clinic, it's a part-time, short-term thing, so these staff will go on to do other jobs after the clinic finishes in either 2 or 3 years. So hopefully that's a benefit to kind of the wider population. Funding for long COVID. So there was a Scottish Government paper which came out at the end of September, which had a figure in it, which was 10 million across Scotland in spending in trying to manage the outcome of long COVID. That's absolutely not just mental health, that's physical health right across the board. I mean, I'm a psychologist. I always say those things are integrated. You can't pull them apart. But there's some areas of medicine have come under more strain because of the outcome for long COVID. GPs are under significantly more strain with people coming through their clinics. AHPs are having to see more people for rehab. So although that 10 million obviously sounds like a large sum of money, that it cuts right across the board. So third sector is mentioned there, and chest, heart and stroke have been following up people with long COVID and are allocated some of that funding. There's been nothing other than I've seen from that. There's been no allocated funding or process by which that will be allocated, but definitely I think the short life working group that Emma Davis is around will be very important. They've been looking at the data, the local data, and where people are and where pressures are in the system. And as we know, even a large sum of money, when it gets disaggregated down to different health boards, then becomes quite a small pot of money, which then, if it's spread out wide across a number of disciplines and areas, then it can become quite sort of smaller. But that Scottish Government paper was published at the end of September, but I've not aware of any other communication. I'm seeing Alan Gray right in front of me, so I'm sure he would know if there's anything that has come down more formally about that.
No, there's nothing yet been announced formally, Maggie. I think there's work still being undertaken to determine how that's going to be allocated, so expect that shortly, but it's not been allocated as yet. Thanks, Maggie.
And you'll see in one of the recommendations, we've also got Emma Davies coming to provide a report in January on progress around the wider post-COVID services and support. So we'll see by then, hopefully we might have some more information. So I see John's taken his hand down because, Kim, you've asked John's question, so we can move on to Sandra MacDonald.
Thank you. And I was going to ask around the gender issue, which Philip did, which was great. But I suppose my question, and we will get more, I'm sure, on this, was around that whole diagnosis of long COVID, and how many cases are we seeing that would have been perhaps diagnosed as ME or other post-viral conditions. You know, I have no sense of that compared to what's coming through as long COVID. And on the hospitalisation, you know, I imagine, but I don't know, if somebody is in hospital because they've got an underlying condition and they contract COVID there, or it becomes apparent that they get COVID, then they would be in this cohort, I guess. But they're not there because they caught COVID. They were there for another reason. Would I be correct in thinking that?
Just taking that final point first, yes, I think it's very, very difficult to differentiate between whether people, I mean, obviously people primarily coming in for COVID, we can identify, but then there are people who caught COVID while in hospital, so had COVID while in hospital, and that was part of maybe their presentation, but also was you know, could have but could have been comorbid in terms of that sense. And at the moment, from the capture, what we're looking at is the people who were in hospital and had COVID. So yes, there'll be people who've got lots of comorbid diagnoses and associated diagnoses, and it is so multifactorial, the impact of COVID-19. You know, some people have no symptoms, as we know, completely, and some people have very severe physical symptoms and a complete systemic, you know, of lots of different areas in terms of cardiac, respiratory. So the rheumatology is another area that a lot of people are coming through. So the impact of this is really quite significant. And I guess we can't differentiate between the people who come into hospital but also have COVID, either as hospital-acquired infection or have come in and then are identified with COVID, and what the impact of COVID is additionally on top of their other health conditions. So all that cohort, yes, it is very complex. They're being treated in a kind of as an overarching group. The other thing to consider is people who had significant pre-morbid mental health issues. And I think for the clinic, that is about being patient-centred, about where best people are placed to have their care. You know, so if they were already involved in CMHTs, perhaps there will be a role for the clinic to have some kind of coordinated approach, but it'll have to be probably down to individual case discussion for some of these people. And yes, absolutely making a very good point about ME post-viral. There is a cohort of people who are presenting in that way, which raise the kind of or sort of resonate with some of the outcomes that we see with people who experience ME post-viral symptoms, and functional conditions is another area which overlaps as well. Through the clinic, because of the expertise that exists within liaison psychiatry, so they are quite used to seeing people who are coming through with very much a mix of mental health and physical problems and ongoing problems which can pervade for various reasons. We're hoping to address that in a similar approach to the way that we do with functional conditions at the moment. We've got a specific functional neurological disorder group which has been showing really good outcomes, so we're going to try and adapt this to fit some of the people that are coming through with COVID-19. It's a 2-session group, education around how your body is physically responding, how you're responding in terms of your mental health, the interaction between those factors, very much trying to get people to manage their condition, identify where they can take the small steps. And as I say, it's very much an engagement and a collaboration with patients, as opposed to the kind of, that's the approach that we would be hoping to take, and it's something which has been effective in conditions which are similar. So people who've had an infection related condition which has then triggered quite a lot of significant psychological issues that may or may not be related to the physical outcomes that they're experiencing. So it is a complex area, and that's one of the things. So actually, yeah, absolutely useful to bring up.
Thank you, Maggie. Sandra,
just very quickly, CMHT, Maggie, what does that stand for?
Oh, Community Mental Health Teams. So
of course it does, yes. When you say it. Thank you.
Thank you, and thanks everyone for those questions, and Maggie for your comprehensive answers. We'll get the slides that we weren't able to see, we'll get them circulated after the meeting so people can see that. So for completeness. I'm not seeing any other questions, so we'll go to the recommendations. Oh, I see Alistair's hands up. Alistair, did you have anything to add, or was it?
Yeah, sorry, I just have to go because I'm in the middle of a clinic. I was just going to say, to pick up Councillor McDonald's point, the money actually was allocated originally. It wasn't even by folk that were in hospital. It was actually those who were in ICU with COVID. That was the original formula, which means, of course, picking up Kim's point, Glasgow have ended up with £1 million to spend. And I think they're having real issues with that, because where are you going to get those people from? You're going to get them from your current services and shift them over. So I think it's a very valid point, you know, that we can have as many specialist services as we like, but actually the people that staff them are going to come from other services. They're not going to be brand new people. Yeah. So I think that's a real challenge for some boards and some areas to deal with.
Thanks, Alistair. It's certainly been a recurring theme of our meeting this morning is about workforce and looking to get new people into the workforce rather than the moving people around services, which just creates pressures elsewhere when our whole system is pressurised. Anyway, thank you. I will move to the recommendations. I'm not intending to read through them word for word, but are we content from what we've heard to note the progress on the development of the COVID mental health clinic in line with Scottish Government guidance, note that recruitment to these posts have progressed, note the additional work on post-COVID symptoms which is underway, request an update report from the Director of Public Health via Emma Davies on that wider post-COVID symptoms, and note the Scottish Government planning for long COVID is outlined in the Scottish Government paper, and there's a link to that there. So yeah, people happy with that? Okay, I'm not seeing anything else. So thanks very much to Maggie and to Alistair for coming along today and giving us that overview. I think it was really informative. Despite our technical challenges, we absolutely got there, and that was a very good report. Thank you. So unless I've missed anything, so Emma, please tell me, I think we're now on to exempt items, well, the one exempt item for business. We've covered the whole agenda for public. So at this point, we can stop the recording of the meeting. Remind everyone that this is now a private session of the IJB, so ensure you're in a private location.